The ACL Performance Enhancement Program consists of progressive plyometrics, beginning around 8 weeks postoperatively, extending 4 to 6 months, and leading up to medical release back to sports activities. Traditional rehabilitation protocols have often utilized a time-based approach to treatment progression. This cookbook approach has often caused clinicians to push their patients more aggressively than appropriate. Also, one of the most controversial and challenging dilemmas to the clinician is deciding when to safely progress a patient from standard rehabilitation into impact and more sport-specific training. The purpose of the following protocol is to take a research-derived, criterion-based approach to progressing a patient all the way back to their given sport. Specific clinical milestones have been outlined and must be met before progressing into the next phase of training. Following such guidelines allows for safe monitoring and control of the many variables that go into progressing rehabilitation as safely and quickly as possible. It has been estimated that up to 90% of all ACL injuries occur from non-contact mechanisms. Clinical studies have indicated that such injuries usually occur during a landing from a jump or from deceleration prior to a change in direction. Usually, this involves an awkward movement or a need to unexpectedly change direction prior to the injury. The same studies have shown there usually is an apparent valgus or dynamic valgus in the coronal plane prior to injury. This vulnerable position, or the point of no return for ACL injury, has been defined as internal femoral rotation, knee valgus, external tibial rotation with foot pronation. Knee flexion angles of 45 degrees or less have shown an increase in anterior tibial shear as the quadriceps is contracting eccentrically to slow the landing momentum. Athletes that demonstrate these mechanics are termed ligament dominant and very susceptible to injury. During all phases of the protocol, we are constantly instructing patients to minimize these faulty movement patterns, stressing that athletes land with strong athletic positioning utilizing the quads, hamstrings, and gluteals to absorb and control the amount of shear at the knee through co-contraction. This form of training is referred to as plyometric exercise. Plyometric exercise can be defined as an activity in which an eccentric muscle contraction or lengthening is quickly followed by a concentric muscle contraction or shortening and is repeated for a given duration. This process of contract-lengthen, contract-shorten is often referred to as the stretch-shortening cycle. Almost all athletic movements involve this stretch-shortening cycle. Plyometrics can be broken up into 4 stages: the pre-activation stage, the concentric stage, the eccentric stage, and the amortization stage. Most injury rehabilitation programs fail to realize that an eccentric muscle contraction can be up to 3 times more forceful than a concentric muscle contraction. This is why plyometric exercises are important in the final stage of rehabilitation, to condition the muscles to handle the added strain of eccentric contractions. Integrating patients back to impact activities requires dosing the intensity, duration, and amount of activity. The suggested frequency of training throughout the impact protocol is 3 days a week on non-consecutive days. In early stages, clinicians have their patients warm up adequately and start the program with entry-level plyometric activities. This prevents poor form secondary to muscular fatigue. Throughout the later stages of this program, patients are challenged to maintain good form even while fatigued. As most injuries occur after fatigue, this trains the athlete to maintain good sound joint mechanics when fatigued. We continue appropriate traditional progressive resistive exercise in conjunction with the impact protocol, targeting muscle groups that display deficiencies. Examples of traditional strength exercises extend far beyond the scope of this DVD. Some important components that everyone should consider include: choose patients appropriately, as not all patients need to reach this level of rehabilitation. Follow functional testing criteria to assure safe participation and progression into each stage. Know the physician, as some surgeons want to prolong soft tissue healing time. When in doubt, contact the physician prior to progressing to more vigorous activity. Utilize rest breaks to restore short-burst creatine phosphate and fast glycolytic energy systems. Double or triple the time duration of the desired exercise for its subsequent rest and recovery period. Encourage patients to be hydrated and properly nourished prior to exercise. Consider proper footwear and use a firm but forgiving surface. Note that correct posture and body alignment is the focus for all stages. Utilize controlled, quiet landings, landing toe to heel for vertical touches, heel to toe for horizontal touches. Minimize amortization stage. The landing on the first jump should be the beginning of the next jump, stressing good, quick, eccentric muscle control. Land with knees bent greater than 60 degrees of flexion. After 60 degrees of flexion, the hamstrings and quadriceps work together through co-contraction. Land with strong, athletic positioning, with the feet shoulder-width apart, knees comfortably flexed, shoulders back, chest over the knees, and the center of balance over the balls of the feet. Avoid dynamic valgus moment or knock knees positioning with landing.